For 2 decades, the global health order rested on a bargain. Wealthy nations would finance, multilateral agencies would coordinate, and the rest of the world would receive. That bargain is fracturing fast, chaotically. Development assistance for health has contracted by a fifth in a single year. Programs are being cut badly. Gains, painstakingly built across a generation in HIV, tuberculosis, malaria, and maternal survival, are now exposed to reversal. And the nations, carrying the heaviest burden of disease, who have had the least say in how the system was designed, are bearing the brunt of its collapse. In Accra in 2025, a summit of African and Global South leaders convened to shake the status quo. The first premise was that health cannot be transformed in isolation. It must be the vanguard of a broader reckoning with the architecture of development itself. From that insight, the Accra Reset was born, a head of state anchored movement that treats sovereignty as a discipline to be mastered and executed with finesse and passion. Health was chosen as the proving ground because no other domain so visibly exposes the distance between rhetoric and lived reality. Where a mother gives birth, where a child is humanized, where a pandemic is contained or spreads unchecked, there shall sovereignty be measured. Accra Reset's health architecture stands on 3 pillars, each addressing a different structural failure, and together, governed by one sovereign logic. First, normative reform, an 18-member high-level panel on global health architecture and governance, co-chaired by Elhadj Nizia Trinidadji, Peter Piot, and Budi Sadikin, with Michelle Sidibe as special advisor, is producing politically anchored recommendations for how the rules should change. Second, institutional interface. Through the high-level consultative group, the Accra Reset engages directly with the WHO, Gavi, the Global Fund, and other key institutions as each undergoes major reform, ensuring that coalition coherence overrides institutional competition. And third, sovereign delivery, hinge. The health infrastructure and investment ecosystem offers an operational engine to convert insights and pledges into real outcomes at the country health. Maternal health, bioinnovation, universal preventive care, designed for countries, governed by countries, and built to scale from the district clinic to the continental supply chain. Accra Reset refuses to treat health spending as a cost line. Its health multiplier doctrine frames health systems as engines that compound value across an entire economy through more productive workers, through industrial capacity in pharmaceuticals and diagnostics, through trade in health commodities across the continent under AFTA, and through the resilience that prevents a single outbreak from erasing a decade of growth. When we invest in health, sovereignty compounds. African leadership in global health is not a novel claim. In April 2001, Olusegun Obasanjo hosted the Abuja summit and stood beside Kofi Annan to demand a global war chest against AIDS, tuberculosis, and malaria. The institution born from that advocacy, the Global Fund, has saved over 65 million lives. Its governance ensured that recipient nations held enough weight for genuine leverage. One leader's foresight wove Africa into the creation pact of a global institution. Geneva is where these currents converge. As key institutions such as the WHO, the Pandemic Fund, Gavi, and the Global Fund navigates their own reforms, the Accra Reset clarion call gathers stakeholders from across the world in one room, at one moment, under one proposition. Sovereignty must be the organizing logic that binds these reforms into a single coherent direction of travel. A new chapter in global health governance begins when those most affected by its failures Lead the redesign. This is a clarion call from Geneva, and the world that answers it will be healthier, fairer, and finally sovereign.
Ladies and gentlemen, would you kindly, please be upstanding for the President of the Republic of Ghana, His Excellency John Dramani Mahama. Mr. President, you are welcome. Akwaba, you are welcome. Please take your seats. Thank you very much. The room is very busy. There's a lot of good energy in the room. Now, we were planning to run a short video by way of a build-up to this afternoon's events. I'm just waiting for my colleagues to let me know if that video is going to play or not. Nope. Fantastic. I like it. Lean and fit. No video, only live human communication. I love it. I love it. Mr. President, John Dramani Mahama, President of the Republic of Ghana. Excellencies, distinguished guests, partners and friends joining us here in Geneva, and everyone watching around the world via live stream, a warm welcome. Vous êtes le bienvenu. And I'm delighted that the focus today is on the Accra Reset high-level dialogue on global health architecture. I feel the energy in the room, and I think I also feel the urgency and the opportunity that brings us together today. My name is Henry Bonsu. That's what they call me in London. But because Mr. President is here, I may need to give you my full name. Henry Nana Kwame Osei Bonsu. Thank you very much. I know you feel it too. It's my privilege to moderate this important gatherings on the margins of the 79th Global Health Assembly. Global health is undergoing the biggest and most sudden transition yet in the 21st century. For more than 2 decades, the architecture of international health cooperation has relied heavily on donor expansion, centralized institutions, and fragmented delivery models. But the pressures on that system are now impossible to ignore. Finance is shrinking, institutions are under strain, and countries across the global south are asking a more fundamental question. How do nations build lasting health sovereignty, the capacity not only to receive support, but to finance, negotiate, produce, and deliver sustainably for themselves? That question sits at the heart of the Accra Reset. Launched by His Excellency, President John Dramani Mahama, the Accra Reset is not simply a call for reform. It is a call for execution, a move from dependency to coordinated country-led delivery. Today's program reflects that shift. You will hear a range of perspectives from heads of state, ministers, multilateral leaders, financing institutions, and global health experts who are directly shaping what the next era of global health cooperation could and should look like. We will examine sovereignty not as a slogan, but as an operational agenda. We will discuss what practical reform requires, and importantly, we'll ask how institutions, financing mechanisms, and partnerships must evolve to enable country-led systems that are resilient, accountable, and sustainable. So thank you very much for being here. Can I get a witness? Thank you. There's spirit in the room. And now to formally open this afternoon's program, it is my pleasure to invite to the podium a gentleman I was having a conversation with a moment or two ago. Filled me with great hope. The Minister of Health of the Republic of Ghana, His Excellency Kwabena Mintah Akandoh. Minister Akandoh has been a leading advocate for equitable health financing, health systems strengthening, and national ownership in health policy, both within Ghana and across broader global discussions. Please join me in welcoming him onto the stage. His Excellency Kwabena Mintah Akandoh.
Your Excellency, the President of the Republic of Ghana, President John Dramani Mahama, Your Excellencies, distinguished ministers, leaders of organizations, partners, friends, ladies and gentlemen. On behalf of the government of Ghana and the Accra Reset Chancery, I welcome all of you to this event. And in Ghana, we say Akwaba. Ladies and gentlemen, as we all know, in life, it is important to pause and reflect. Reflection helps us to gain more wisdom and improve. Today, we are here in Geneva, the storied home of global health, ready to reflect and build the next phase of the global health architecture on a firmer grounds. I am honored to welcome a leader whose vision centers on sovereignty, dignity, and self-determination in development and global cooperation. At a time when the global health architecture faces unprecedented strain, President John Dramani Mahama urges us to build a system anchored in country ownership, resilience, and accountability. This is a historical moment. The global health architecture, built over 80 years on solidarity, now strains under pressures it was not designed to bear. In just 1 year, $8 billion was cut from international development assistance. 2 decades of progress against HIV, tuberculosis, and malaria are at risk. What this means is that clinics closed doors, and in some cases, mothers and children failed to live. It would have been easy to lament, but under His Excellency President John Dramani Mahama's leadership, with co-convener President Basu, Global Presidential Council, and a high-level panel, Ghana chose to build, not to lament. The Accra Reset is not a critique, it's a construction. It does not request a seat at another table, it sets its own. It moves nations, the global south, from passive recipient of aid to sovereign architects of our own health systems. Ladies and gentlemen, His Excellency John Dramani Mahama understands no nation can demand reform from elsewhere if it is unwilling to demonstrate it at home. Now, I'm going to tell you how we are demonstrating it at home. In just 12 months, Ghana uncapped the National Health Insurance Fund, restoring over 300 million USD to the health budget. This expanded the funds available for our national health insurance by over 30%. As a result of the increased confidence, over 2 million more Ghanaians joined the National Health Insurance Scheme, increasing coverage from 57% to 66%. In addition, we established a fund with an annual budget of over $200 million dedicated to specialist care for NCDs, called the Ghana Medical Trust Fund, aptly christened Mahama Cares. We are still forging on. Under President Mahama's leadership, just a month ago, Ghana launched a free primary healthcare program funded solely with domestic funds. Ladies and gentlemen, this is what sovereignty looks like. As a Minister of Health, I am privileged to serve with a president whose vision for health sovereignty transcends borders and reshapes global health. It's an honor to support his mission, which demands we move beyond old health architectures and build something more equitable, just, and rooted in the dignity of nations shaping their own destinies. More than half a century ago, Ghana's founding president, Dr. Kwame Nkrumah, declared, "We face neither east nor west, we face forward." The president you are about to hear faces forward with that same courage and conviction, determined that the children of Ghana, Africa, and the global South are worth every step. A man who has risen through the ranks from the lowest level of elected office at the sub-national level all the way to the national and the highest position on the land in Ghana. He has been the assembly member. He became member of parliament, became a deputy minister, became a substantive minister, he became the vice president of the land, he became the president and became a president. Some call him a statesman, a reformer, reparations champion, and an African Union champion for African financial institutions. But today, I'll call him what history will call him, an architect of a fairer world. Your Excellencies, ladies and gentlemen, please let us rise at this point in time to welcome His Excellency John Dramani Mahama.
Thank you, thank you. Kindly resume your seats, thank you. Let me just proceed on the protocols already established and express how appreciative I am to be here this afternoon for this side event on the Accra Reset. One afternoon, I was sitting in my residence, minding my own business, and a certain retired general, retired president, former president, Obasanjo, appeared with a long retinue of people, Magda and all of them. It's about 7 of them, and said, "Mr. President, there's something happening. You know, humanitarian assistance is dwindling, ODA is falling. It is time for Africa to take its destiny into its own hands." And I said, "Oh, Mr. Obasanjo, I have too much on my plate. I just took over as president. Our economy is in a shambles. I have so much work to do. I don't have time for another of your many courses." But President Obasanjo is not somebody you can say no to. He cajoled me, he commanded me, did everything in the book. And here I am, champion of Accra Reset. You know, the global architecture is changing. Some people feel that they can go on their own. But what you forget is that we're passengers in the same bus. And that bus is this globe. No country can live in isolation. There are some things we cannot deal with alone. We need to come together as a world to do that. And the only way we can do it is through the multilateral institutions that we have. And so if you say you don't want to have anything to do with World Health Organization, we're withdrawing funding and all that, they say it's not a matter of if, it's a matter of when the next pandemic would hit. And pandemics know no citizens. They don't know Ghanaians, they don't know Britons, they don't know Swiss, they don't know Americans, they don't know Africans, they don't know Asians, they don't know Caucasians. If pandemics hit, they are indiscriminate. Today, he is having to run back to Congo because of the outbreak of Ebola. And it's ironic, some of those organizations that people are withdrawing from and gutting have helped to evacuate some of their citizens from the epicenter of the Ebola outbreak. And so the multilateral institution you thought was not fit for purpose, today you are relying on to safely evacuate your citizens from the hantavirus ship, from Ituri, where some of them are working as medical officers. And so we should have a rethink. We should act locally, but think globally. And so we do all in our power, in our own countries, to try and take our destinies into our own hands. And in Ghana, we are walking the talk, like the minister was saying. Since last year, we've increased coverage to 66% of the National Health Insurance Scheme. But what of the other 34% without coverage? And financing at the point of care is the most critical. And so, like he said, we introduced the free primary health care this year successfully using our own funding. And it was a joy to see the healthcare workers who work especially in the rural areas, from the CHIPS compounds to the health centers to the polyclinics. It is free of charge for every Ghanaian who shows an identity card and goes for treatment. And so that day we handed over equipment to them. They got scan machines, they got tricycles, and indeed there was some uproar about the tricycles. Some people misidentified them as ambulances and said, look at the ambulances Mahama is bringing. I mean, what kind of ambulance is this? You know, the tricycles were actually meant for health screening, so that for those who don't know how to ride a motorcycle, they could use the tricycle to go to the communities to do health screening. But then the point I thought was, yeah, so if your wife were bleeding and was due for childbirth, and there was only that tricycle in the village, will it become an ambulance or it won't become an ambulance? If it is only that tricycle that can evacuate her, an ambulance is anything that emergency you use to move a patient from point A to point B in order to save their lives. But that is all by the side. We have a lot of work to do. Even though we've increased investment, we uncapped the national health insurance, and it freed up $300 million of extra funding for our health system. And that is what has helped us to do a lot of the things we're doing. There's an explosion of non-communicable diseases, mostly caused by lifestyle, changing lifestyles. Our societies are modernizing. People don't engage in too much physical activity anymore. And yet some of our foods were invented by our ancestors to provide us with energy for physical activity. Africans were very physical. Today, we're no more physical. We wake up in the morning, drive to work, you know, sit in an air-conditioned office the whole day, close in the evening, drive to the nearby pub, sit with your friends, have a drink, then you drive home, and you get home late, and you're hungry, and you ask for food. And I use the example of banku. It's a doughy kind of food made from maize, high in carbohydrates, and it can be heavy in the stomach. And then you eat that and go straight to bed. And so we have cardio incidents, we have explosion of diabetes, we have kidney ailments, we have cancers, different kinds of cancers. And the treatment has been very expensive. And so we decided to introduce what he said, the Ghana Medical Trust Fund. In many households, if one of the members is afflicted by any of these diseases, it means running the whole household into poverty. And so it was necessary for government to stretch a helping hand. So we set up the Mahama cares and put about 2.1 billion cedis into it. But it's not only providing funding for treatment, it is also providing the facilities. In many cases, it's not just about having money to pay for the treatment. In many cases, the treatment is not even available. It was after we set up Mahama Cares, we found that there's no cardio center in the whole of the 5 northern regions. If you have a cardio event, you have to be evacuated to the middle of the country or to the south, to the capital. And so Mahama Cares is putting up a cardio center with all the specialized machines, cath labs, everything, so that people can get care. We have to create more oncology centers so that people with cancers and all that, can have a cure. But there's a lot to do, especially with efficiency. We must make sure that every cedi we spend, we get value for money. And that is going to be the next frontier that we have to look at, to make sure that for every cedi, we're spending it efficiently. We're estimated to be at below 50% in terms of efficiency. And so it means for every dollar, we're losing 50 cents. If we're able to increase efficiency and, expand that to 100 cents for every dollar, then it means that we can spare some more money to train more personnel, put in facilities and all that. But today, we came to plumb the depths that we haven't opened for a long time and to speak the prose of reality. And I want to begin with a story of the Indonesian city of Bandung. In 1955, 29 nations representing 1.5 billion people gathered in Bandung, Indonesia. This meeting birthed the non-aligned movement, whose main objectives were respect for the sovereignty of nations, equality of races, anti-colonialism, non-aggression, South-South cooperation, and peaceful coexistence. That conference produced neither a binding treaty nor a budget. Bandung was quite provocative and radical at the time, in a period where superpowers were competing for dominance in world affairs. And so this produced what came to be known as the Bandung spirit. The Bandung spirit came to represent sovereignty, self-determination, non-alignment, and equality. But Bandung has another story that is very little known for. Many years before the Bandung conference, a state-owned vaccine institute was built by the Indonesian government called Pak Vaccinogen. This was established in Bandung and later was renamed Biopharma. Today, Biopharma is the largest vaccine producer in Southeast Asia, supplying 150 countries with vaccines. This establishment developed the novel polio vaccine. They secured WHO certification and transferred the technology to India. This is one single story of sovereignty. And so there are 2 stories of Bandung. The Bandung, where the first Bandung conference was held, and the Bandung where this little vaccine institute that birthed into a giant oak tree was born. One of these Bandungs is the one in which beautiful speeches and exhortations were made. And another of the stories is the one in which a little investment in vaccine science and research has birthed a global vaccine powerhouse. The Accra Reset intends to close the gap between the 2 stories of Bandung, the beautiful oratory and exhortation, and the planting of actual implementation on the ground. And so we are here to break the distance between declarations we make at podiums and the factories and clinics we build on the ground. And so we're moving from speech to action. When we introduced the Accra Reset in Davos in January, we met a mixture of excitement and skepticism. And people asked, is this another talk shop? How does it work and who will pay for it? We spent the last few months answering these questions with action. First, we set up the high-level panel. This is not a ceremonial board, it's an independent body of 18 experts from 6 continents, co-chaired by giants who led Brazil's Fiocruz and Indonesia's pandemic response. Under the guidance of our special advisor, Michelle Sidibe, this panel reports to heads of states, not to the institutions it scrutinizes. They began their substantive work here in Geneva this afternoon. Second, we've operationalized the Reform Interlochen Observatory, RIO. In this room this evening are heads of the Global Fund, Gavi, and WHO. And let me be candid, when our partner strategies are designed in isolation, the recipient countries bear the cost of the incoherence. So RIO is our 100 eyes, which will track these reforms simultaneously to ensure that when the 14th General Program of Work meets Gavi's LEAP, they make sense on the ground in Africa, Jakarta, and Rio. And thirdly, last week in Kigali, the Sankuri Institute of Global Negotiators was outdoored. We're tired of arriving at procurement tables with nothing but goodwill, only to leave with shackling conditionalities. The Sankuri Institute of Global Negotiators will ensure that when we negotiate technology transfer or voluntary licensing, our team is as sophisticated as our counterpart. But even with reform and negotiation, we need a switchover mechanism. The architecture of global health was built in 1948, when most of Africa was still colonized. It was designed with the assumption that financing comes from outside and standards are set elsewhere, and Africa is just the consumer. Today, as the AU champion of African multilateral financial institutions, it is estimated that Africa has over $2 trillion in investable funds. The Afrexim Bank has pledged $2 billion for manufacturing. The political will is there and the funding is there. What is missing are investment-ready pipelines. And so Hinge, the Health Investment National Gateway Enablers, is our response. It is a deal room, not a boardroom. It will focus on maternal health and bioinnovation. And our commitment is simple but aggressive. We will deliver bankable co-finance deals within 2 years. 24 months, not 24 years of communiques, not 24 validation workshops. We've asked the IFC, the AFD, and the Afrexim Bank to join us in a post-summit retreat to anchor the first structured deal room before the UN General Assembly is held in September this year. We cannot afford a leisurely pace when 182,000 women in sub-Saharan Africa are going to die this year in childbirth. For those who think the Accra Reset is a fleeting performance, we're digging in. Our coalition is backed by a presidential council from across Africa, Latin America, and Asia. Our guardian circle includes leaders like President Obasanjo, President Johnson Sirleaf, and Gro Harlem Brundtland. These are people who do not show up for pretty photo opportunities. They have proven track records of working for the advancement of our world. And furthermore, we will lead by example. And as I said already, in Ghana's 2026 budget, we allocated 34 billion cedis, that's $3.4 billion to healthcare alone. As we move into panel discussions this evening, I want one question to ring in this room. While we talk and plan here in Geneva, all the health workers in the CHIPS compounds in the northern region of Ghana want to know is when these reforms we talk about will make a difference in the healthcare outcomes of the communities they serve. They don't care about the nomenclature, global health architecture, and all the beautiful jargon we throw around. Blueprints and plans don't fit on their phone screens. All they care about is how vital supplies can reach them on time, whether they can safely transport a referred mother on a 3-hour journey to the nearest district hospital. And so let our meeting here in Geneva talk to these rural health workers through a partnership that involves African governments stepping up also to the plate. The Akan people of Ghana say, there's nothing wrong with reaching back to fetch what you forgot. And that's the famous Sankofa bed. What we forgot is our agency. And so tonight we must reach back to the spirit of Bandung and march forward claiming our sovereignty. We're stretching forth our hands and claiming our destiny, and let our partners march along with us. After all is said, that if you want to go far, you go together. We want to go far, and so we will go together with our partners. I thank you for your attention.
Mr. President, thank you very much. Mr. President, thank you very much for that stirring speech, invoking the spirit of Bandung and the elegance and wisdom of the Sankofa bird. You said it was a clear challenge to the global community and all of us here with that question. When will the people, those community health workers in the hinterlands, feel the impact of what we do and say here today? And you set a challenge to the global community gathering here this week. Sovereignty must move beyond aspiration and become executable policy and financing and delivery. And I should add that it's in keeping with your leadership, Mr. President, in other areas, including agriculture, cocoa. I followed your statements on that, and even fashion on culture. It's because of what happened to you in Zambia some time ago that I'm wearing my fugu proudly today, even though it's not Friday. I was going to leave it at home. I decided to unretire this garment because of you, sir. Thank you very much indeed. Our next speaker has spent her career working at the intersection of frontline medicine, health systems, and global health policy. Dr. Vanessa Kerry is a critical care physician, chief executive of SEED Global Health, WHO Special Envoy for Climate Change and Health Associate Professor at Harvard, whose work has focused on strengthening health workforce capacity and building resilient health systems at the invitation of governments in Africa. Today, with colleagues at SEED Global Health and Harvard, she is releasing new preliminary research mapping the rapidly evolving global health reform landscape. Please, mesdames et messieurs, welcome Dr. Vanessa Kerry.
Good afternoon, Your Excellencies and distinguished guests. I'm incredibly honored to follow His Excellency President Mahama and to acknowledge his leadership for what he has set forth with the Accra Reset in such an important moment in global health. And the vision that was just laid out and the vision of the Accra Reset as it has been unfolding over these months is very much a lot of what I will talk about actually today and what was found in the study that we'll talk about. But what I'd like to do is I want to begin by reflecting on a conversation that I had last month. I was in the room with some of the world's biggest philanthropies and tech companies to discuss the future of global health. And there was huge excitement about the potential of AI to deliver faster, cheaper, and further into underserved communities. And while there's no doubt that AI is transforming healthcare, I found myself returning to the simple truth. Technology is only as strong as the systems into which it is introduced and the hands of the people who use it. In healthcare delivery, AI still depends on nurses, doctors, midwives, community health workers, reliable electricity, medicines being in stock, and patients actually being able to reach care. But what struck me the most was how little the conversation focused on what countries themselves might actually want from this technology. And it perfectly captures the moment that we find ourselves in. today. Across global health, we've become very good at designing solutions, whether new technologies, financing mechanisms, or reform agendas. But we have been far less effective at building the systems capable of sustaining them, or in supporting countries to meet their ambitions and needs. Over decades, fragmented financing, parallel programs, and decisions that are often shaped farthest from the people on the front line of care have created enormous complexity while not addressing major structural changes. And unfortunately, while there is now growing consensus that global health must evolve, there is still far less agreement on how reform is aligned, implemented, or sustained in practice. That is precisely why what we do in this moment matters so much. Quite literally, billions of lives depend on all of us in this room and all of us who are part of this process to get this right. And recognizing that we cannot afford to repeat old patterns in new ways, my colleagues at Seed Global Health and at the Harvard School of Public Health, with the support of the Rockefeller Foundation, set out to understand where global health reform is converging and where there is tension, where there are gaps, where there's duplication or fragmentation. So published over this weekend, this is one of the first or comprehensive mapping of the 11 major global health reform initiatives. These include many of the initiatives that we're going to touch upon this whole week, and certainly includes ones that we just heard about with the Accra Reset. And we will be hearing these processes. It's worth noting this paper is a snapshot in time. This is under evolution, but this snapshot is important when we think about where we are today and where we are going to go forward. So I want to share the highlights of what we found. First, the good news. Consensus exists. There is remarkable agreement on the need and direction of reform. Across all the initiatives, we found growing alignment around the principles of country ownership, stronger national systems, sustainable financing, and the need to move beyond fragmented project-based approaches. But a caution, because agreement on direction is not the same as agreement on delivery. And while the sector is increasingly aligned on what needs to change, there is not yet enough agreement behind some of these major initiatives or agreement on how the reforms are actually to be carried out. So this next phase that we embark on from today onwards, after hearing the words of President Mahama who laid out what the vision can be, we have to have a coherent implementation roadmap. We must decide how efforts complement one another, who leads what, how countries are best supported as external financing continues to evolve, and how implementation actually happens in practice. Initiatives like those that we're going to hear about this week, we hear about today or earlier today, are all major opportunities to bring governments and partners together around these very questions and to model collaboration across initiatives. Because our second major finding was that with so many reforms, we risk furthering the very fragmentation we are trying to solve. At the same moment countries are confronting shrinking resources and rising health pressures, they're also being asked to navigate multiple overlapping reform processes. And despite language around sovereignty and country ownership, the truth is those who control funding still shape priorities based on their own political pressures and interests. We should not be redesigning or reinforcing systems that make countries navigate multiple parallel financing streams, reporting systems, and platforms just to strengthen their health systems. We should all be aspiring to a future where there is one national plan, one coordinated financing framework, and one reporting approach, but a system that is led by the country in service to the country's people and managed and really developed and put forward by the country's government. Third, We found that the financing transition may become one of the most defining challenges of global health reform. Just as countries are being pushed towards greater self-financing for health, they're also seeking greater sovereignty for their own health priorities. But the path to get there will be untenable if countries are being crushed by unsustainable debt burdens and left with too few resources to meet critical health needs and to make these transitions in the meantime. Domestic resource mobilization is essential to long-term sustainability and resilience, but a transition away from external financing must be realistic, carefully sequenced over time. Because the risk is, if we shift too quickly, countries will be left with gaps that they can't realistically close. Hard-won progress will be lost. And critical domains like workforce will be left underfunded. And the global public goods that have long been supported by external financing will begin to erode. So fourth, in pursuit of country sovereignty, we can't abandon multilateralism. We need both. Countries should set their own priorities, and multilateral institutions should help countries deliver on them. Because pandemics, climate shocks, outbreaks, and health insecurity do not stop at borders. They require global collaboration and global support. And beneath these tensions sits the fifth and potentially most critical finding. Reform will only succeed if countries have the capacity to deliver it. Across reform discussions, there is still not enough focus on the systems, institutions, and workforce that deliver care. That means skilled health workforce and reliable supply chains, referral systems, stable, clean energy, and reliable financing, among other things. These are not nice to haves. They are the foundation on which reforms and ultimately health systems will succeed or fail. So this is not actually a debate about architecture. This is a debate really about whether reforms will deliver quality care to people when they need it most. Whether a mother survives childbirth, whether a child receives life-saving treatment, whether a health system holds in a moment of crisis. Our debate now is with ourselves. Do we have the courage? And I think we do. We just heard a story, the country that is moving us to courage. To move beyond these fragmented systems, though, in short-term politics, we all have to step into that frame and to align behind country priorities, to build resilience in the face of climate change, pandemics, and growing health insecurity, and to create a future where access to quality care is not determined by where someone is born. Because this moment requires more than new language. It demands transformation, action, and courage. And if we get this right, we will not only save lives, but we will build a healthier, safer, wealthier, more just, and resilient world. Thank you.
Dr. Vanessa Kerry, thank you very much for bringing us the findings from your research, from your work, some pretty alarming conclusions, which we'll have to digest and hopefully act upon. I like this mantra, one national plan, one financial framework led by the country's government. But the gap between those aspirations and the capacity is something that we have to bridge. But thank you very much indeed. One more time, Dr. Vanessa Kerry. Thank you very much. Okay, we move now into the first major dialogue of the afternoon. And this conversation focuses on one of the central questions facing global health today. What does country-led delivery actually require in practice? Too often, reform conversations remain trapped at the level of principle, but ministers and leaders operating inside national systems are confronting implementation realities every day, balancing sovereignty, financial pressures, institutional coordination, alignment, and population needs in real time. As His Excellency the President was talking about. Now, this panel brings together leaders whose experiences span national reform, multilateral engagement, and implementation at scale. As I invite our panelists to the stage, I'll briefly introduce them. Please welcome His Excellency Budi Gunadi Sadikin, Minister of Health of the Republic of Indonesia. His Excellency Dr. Alexandra Padilla, Minister of Health of Brazil. His Excellency Aden Duale, Minister of Health, Kenya. Mr. Elhadj C, Chair of the Board of the Kofi Annan Foundation. And Dr. Magda Robalo, President and co-founder of the Institute for Global Health and Development. Ladies and gentlemen, please welcome our distinguished panel. Thank you very much indeed. And as you can see, we've got a clock here, digital, so we are on the clock, as it were. So I would invite you to leave the things you don't want to say out of the room and only make it count here. That's what we want, because there's some key questions that we want to try and address. Minister Budi, I'm going to start off with you. You and I encountered each other in September at the UN General Assembly when I was recording an interview with you for a podcast called The Threshold, produced by Foreign Policy. And we talked about the remarkable transformation that you managed to bring to Indonesia from aid dependency to sovereign, self-directed health financing. You told me at the beginning of our conversation, Mr. Bonsu, I'm not even a health guy. I came from the world of finance, but I know how to make the numbers count. But like Peter Sands there, he went like this. As soon as I mentioned finance, he went like this. So let me ask you this question. What were the most critical shifts, political, financial, or institutional, that enabled the transition from aid dependency to sovereign self-directed health financing, achieving near universal health coverage in just a decade? And if you know Indonesia and the spread of your islands, my word, it's not a small brief. So please explain, what was the most critical thing?
First, I would like to thank President Mahama, because as a graduate, a physics graduate from Bandung Institute of Technology, and I met my wife and married her in Bandung. So thank you, because you mentioned Bandung more than 10 times. Second, I'm working in finance for the last 30 years. I used to run the largest bank in the country. So I saw the Asian financial crisis started in Thailand, 1998. And then mortgage crisis, global mortgage-backed security crisis, US, 2008. Many banks closed, like Merrill Lynch and Lehman Brothers. And then European bond crisis in 2010, 2012. And I thought, when the president sent me to be the first health minister without medical background in 2020, I thought I will never see a financial crisis. And then here we are, another financial crisis in healthcare sector. So let me share Indonesian cases. After I finished the only task given by the president to manage the pandemic, looking for vaccine, delivering 400 million jab to 200 million Indonesian in 7,000 islands, then I realized we do not have enough health delivery systems. President Mahama mentioned about cardiovascular diseases. Indonesia consists of 514 cities. We only have 44 cities that can handle stroke and heart attack. 44 cities with CT scan and cath labs. We have breast cancer death. 514 cities, we only have 60 cities with mammograms. You know, we have 4.8 million babies every year, ranked number 3 in the world. Maternal mortality is extremely high. Because why? Because we deliver those babies in 10,000 primary healthcare clinics, only 2,200 have ultrasound. We only have 1 PET scan in Jakarta, 1 PET scan to serve 280 million people. So what I did at that time, I need to massively revamp the healthcare infrastructure in primary care and also secondary care. We don't have money. We don't have money back in 2022. But banker skill is to look for money. So then in 3 months, I got $4 billion loan for the 4 MDBs to revamp 10,000 primary healthcare clinics across 7,000 inhabited islands and 514 hospitals. We bought 400 CT scans, 50 MRI, 400 cath labs, and mammograms, 500 mammograms, also pathology lab in 514 cities, LINAC in 34 provinces, 16 PET scan, cyclotron. We buy all of them with the World Bank money. So ladies and gentlemen, money is there, as Peter said, but it comes with a different format. It's not free money in a grant, but it's money in the loan. And I look at the financial crisis in healthcare sectors. It's only about 20 to 30 billion. In 2000, before COVID, the ODA in healthcare is about 40 billion, move up to 60 billion, and then move down again 40 or 30 billion. We lost 30 to 20 billion US. That is the largest bank in the world called World Bank. They disburse 80 billion, 90 billion every year. If you compare with AIIB, you put ISDB, Asian Development Bank, they can disburse easily 100 to 150 billion. So 20 billion, you don't get it from the grant. You get it from the bank. If you don't have money, what would you do? Asking your father and mother or go to the bank? You go to the bank. So that is the reason if we find a way how to do it, actually money is there. We need to structure it a little bit. And we need to help the health ministers because they cannot talk even to their finance minister to justify the funding. How can they talk to the banks? So my proposal as the Accra Reset co-chair in financing sector, I would like to help all countries, develop a proper plan, healthcare financing pathways. So you can convince your finance ministers, then you can convince your leader like great President Mahama and convince the big banks to lend you money. Thank you.
Minister Budi, thank you very much. And if you look at the clock right here, 0302, on time and on budget. Of course you were. Of course you were. I can see now why you are the chair of the finance pillar of the high-level panel. You wear it well. You wear it well, sir. Okay, but let us move to Minister Padilla from Brazil. Under President Lula, your country has been one of the most vocal advocates for global South solidarity in health. And Brazil, of course, sits on the Accra Reset presidential panel. And I'm wondering what Brazilian leadership looks like in concrete terms. So you're advancing Brazil's national priorities, but you also want to shift global norms of health governance through multilateral platforms like the G20, COP, and World Health Assembly. So can you explain how you're doing this, Brazilian leadership?
Thank you for your question. Esteemed fellow panelists, ladies and gentlemen, President of Ghana, dear colleagues, Brazil considers that the current moment requires more than adjustment to the global health architecture. It requires a political rebalancing of global health governance itself. Under President Lula, Brazil has consistently affirmed that countries of the global South must play a central role in shaping global decisions, advancing innovation, and contribute to the design of financing and technology frameworks that reflect their realities and priorities. We must increase defined pathways and build sustainable national capacity, aligning with global health guidelines defined by WHO in consultation with all member states and safeguarding, whenever possible, social participation. Health sovereignty is not merely an aspiration or a rhetorical concept. It's an executable agenda grounded in stronger national health systems, sustainable financing, local and regional production capacity, science, technology, and a resilient public institution. This is precisely why Brazil sees the Accra Reset as an important political initiative. My presence on this panel today is due to the President Luiz Inácio Lula da Silva's support to the Accra Reset endeavor to build a new paradigm for global development cooperation through practical cooperation among countries of the Global South. At that moment, our former minister, Nisia Trindade, who played an important role in strengthening Brazil's engagement on equity, health sovereignty, and international cooperation within global health debates. Our priorities on the global health agenda are to promote equity, production, innovation, and access in the Global South, the adaptation of the health systems to climate change, and attention to the social determinants of health. During the Brazilian G20 presidency, for example, there was launched the Global Coalition for Local and Regional Production, Innovation, and Equitable Access, based on understanding that defending health sovereignty equals strengthening local and regional production capacities, especially for population historically left behind by the global innovation. Additionally, at COP30, Brazil has defended a very clear message: climate adaptation and resilience in public health systems. In November, we present the Belém Health Action Plan, inviting states that have been approved in the COP30, inviting the international organization, philanthropists, civil society, and private sector to build and strengthen national health system and resilience adapted to climate change. The plan reflects our understanding that climate crisis is a public health crisis. Once we are already dealing with transforming epidemiological realities, increasing inequalities, and placing enormous pressure on health systems. Climate change is also an agenda of equity, territorial protection, and social justice, especially for vulnerable communities disproportionately affected by extreme climate events. If I may say, Brazil's main contribution to the reform of the global health architecture is advocating, participating, and contributing to initiatives that understand that the present and the future of global health governance cannot continue to rely on vertical approach that often reproduce dependency and asymmetries. In this context, Global South cooperation represents not merely an alternative to multilateralism, but an opportunity to renew it, making global governments more balanced, more representative, and more inclusive of developing countries in decision-making process, while remaining genuinely connected to the realities and priorities of our peoples and communities. This is the spirit in which we engage here today. Thank you.
Thank you very much indeed, Minister Padilla, and I believe you do have to leave us now, I understand. So thank you very much for your contribution. Thank you. Minister Padilla, thank you. We won't leave you hanging. We'll clap you off the stage. Minister, thank you very much indeed. Okay. We'll now move to Minister Duale from Kenya, which was the scene of the Africa Forward Summit, which was widely reported on last week, and health was one of the biggest focuses, actually. Something like 942 million euros in commitments aimed at strengthening pharmaceutical manufacturing and health systems across Africa. And this is interesting, and I was wondering why health is the vanguard sector for this new era of international cooperation.
Thank you very much. And thank you, President Mahama, for inviting me to and for spearheading the Accra initiative. Thank you, because President Mahama's second home is Kenya, so I'm viewing President Ruto sitting here. So if I go over the mark, then you will excuse me. But I think you have asked a very good question. Kenya and Ghana are leading in terms of creating a practical health sovereignty. And how do we do that? By making sure that we take charge of the health systems and health financing in our country. So in Kenya, we started with, after the global financial, global shifts, we started by first enacting very critical pieces of legislation: the Primary Health Care Act, the Social Health Authority, the Social Health Insurance Act, and the Emergency Chronic and Critical Illness Fund Act. And we have so far, in 18 months, mobilized domestically to fund our healthcare and universal health coverage, about 180 billion Kenyan shillings, equivalent of $1.4 billion. So it is possible, it is practical to raise funds. And how do we raise these funds? Primary health care in our country is free. It's paid, like Ghana is paid by government. So every Kenyan who walks to level 2, level 3, dispensary and health centers, for outpatient, goes, is treated, sees a doctor, gets a lab test, goes home free. When you need a specialized care, then you graduate to the Social Health Insurance Fund. And how is the architecture of the Social Health Insurance Fund in our country? It is 2.75% of everybody's income, whether working in the public or in the private sector. So the president, the minister pays more, the person at the bottom of the pyramid pays less. So it's pulling resources together. The lady in the market will pay less, the president will pay more based on the income. And that's how we have raised that resources. As of today, in a population of 55 million, 31.8 million Kenyans have registered by this morning. Secondly, and more fundamentally, we have the emergency chronic and critical illness fund. And this is, it caters for emergency, it caters for chronic illness like cancer. Once a cancer patient exhausts his premium and he has not much extra money, then he graduates to that fund. But more fundamentally, I think I need to say is that within the universal health coverage, we care about the human resource healthcare. So we have employed close to 107,000 community health workers who are frontline healthcare workers. They take care of the people in the villages and in their homes. Then we have done something that has never happened in our country. We have, for the first time, digitized our complete health system. From the doctors, the patients, to the theaters. All our citizens have apps called Afya Yangu, My Health. That's where they register, that's where they pay, that's where they see their premium, that's where they see facilities, that's where they can see their doctor. Our doctors have an app called Practice 360. So the doctor can view the facility, we know his scope of service, his qualification, has he paid his fees with. And that is to get rid of quack doctors in our system. Mm-hmm. Then we have the logistics arm, where we make sure that there's track and trace. Every drug that a patient gets in Kenya can be traced digitally to the manufacturer. And then finally, what are we doing? We're doing what is called commodity and technology security. We want to make sure that there are drugs in each and every public, private, and faith-based health facility. And the last one, I think, which President Mahama talked about is, we have introduced something called fee for service. We've spoken to vendors and suppliers of key health equipment. So they go place in any facility from level 4 to level 6, and they are paid for. When a patient, government doesn't pay, doesn't buy, they place it there, they service. When patients uses, their reimbursement are done by the Social Health Authority. That's how we do it in Kenya. And I think by December, we want to make sure that we've covered 90% of our citizens.
That's tremendous. Minister Duale, thank you very much. Some really good practical examples of health sovereignty from the Kenyan perspective.
And I'm not a doctor.
You're not a doctor either?
I am a doctor. I am a politician.
I can see a theme is emerging here. Maybe it is one to be encouraged. I'm sure some of you would agree. Okay, so we're going to move from a country perspective to an agency and indeed a foundation perspective. We have Mr. Elhadj as C, who is with us also. And so you're a member of the high-level panel mandated to move global health reform from principle to implementation. We've heard from the president, we heard from Vanessa, Kerry, about the gaps that exist, because it's great to have the plans and the principles, but what about that person in the hinterland in Brongahafo, up in the north of Ghana, or in Bolgatanga, some of these places, you see, where they don't know about what is going on here. And I'm just wondering how confident you are that finally change is going to happen, that we can fill that gap between reform and implementation? Given what you've heard.
Yeah, thank you very much. We in the high-level panel, some of the questions that we are getting asked very often may indicate that, we're about moving the pieces of a puzzle of global organizations that are working on health from different perspectives and at times also with different interests. And my answer is, Accra Reset is not about that. Many of those organizations are under the umbrella of the United Nations. And there are three words that open the preamble of the UN, that is we, the people. So who are those people? Those people are citizens of Ghana and Africa and the Global South. We are exercising now their active citizenship and calling for a number of issues. They're calling for equity. They're calling for fairer trade. They're calling for better health. They're calling for sustainable financing. They're calling for sovereignty. But they're also calling for governance and accountability. Governance and accountability because we can all play mea culpa by realizing that over the years we've made so many promises and we've delivered on very few, and then no accountability down the line. And what is the consequences of that? One of the biggest consequences is the erosion of trust. Trust in the organizations, trust in leadership. So the citizens on our continent, they have a median age of 19. 75% are younger than 35. They're impatient. They're angry at times, and rightly so. At times also in those places where the health challenges are greatest and the resources are scarce, like in Ituri today, or at the border between Afghanistan and Pakistan, or in northern Nigeria in the Sahel. They cry for peace, so that health can be delivered. So Accra Reset then is a leadership response. A leadership response to that call. The leadership response, to that cry of the citizens through action, but also through creating, a movement based on sovereignty, but not sovereignty in isolation. That action will be contributing into shaping a global agenda, which is the first step before shaping a global structure. The structure may follow after. The analyses have been made by many. Cases have been made by some. The question is, what do we do with the analysis and what do we do with the case? It will not be a technical solution to a political problem. We will have now to land on a political path and put those analyses and recommendations in the hands of political leaders to take it forward. There are some very important strains already emerging from the analysis and the recommendations that we will be putting in the hands of President Mahama and the Presidential Council. And they will be articulated, as you all know, on some of the crying desire of our time. Sovereignty through local manufacturing of health products and commodities, so that the Global South will not continuously depend on products they need and then will be produced everywhere. There will be definitely a financial stream to ensure that there will be a sustainable financing of health, led by Minister Budi. They cry also for primary health care, but not only that. While they call for back to primary health care, those young citizens also are shooting for digital health and AI and everything in between. Now, when all of that is said and done, the landing pass that we will be putting in terms of a recommendation in the hands of the President Council to move forward, then that's what the Accra Reset will be about. Thank you.
Thank you very much indeed, Mr. C. And now I invite Dr. Magda Robalo to give us her thoughts. And I'm just considering what we've heard thus far. We've heard from President Mahama about the innovations he's introduced since returning to office, Mahama Cares, broadening the insurance coverage towards universal health coverage. We've heard from Minister Budi, Indonesia, no health qualification, but he knows how to get money, which is fantastic. We heard from Minister Padilla from Brazil, linking climate sovereignty to health sovereignty. And we've also heard the example of Kenya, Mr. Douala, taxation, broadening the tax base and supporting all those community health workers, over 100,000 of them. And you're on the high-level panel. I'm just wondering what you make of what you've heard and what you would like to see more of from the examples, or perhaps things you haven't yet heard. This is the question. I'm just putting you on the spot. I don't want you to go over the ground we've already gone. And I know from our conversation before, Andy said, give me something. I'm ready to take any question. So please.
Thank you very much for putting me on the spot. Your Excellency, President Mahama, distinguished guests, I won't be coherent if I do not resonate with some of the things that have been said here today. The 5 shifts I'm going to propose to you are somehow related to the cry of the people and based on the goal of universal health coverage that we are aiming to achieve. I want to talk about equity-driven governance, which is based on real and timely data. And we need to say no. This is the shift. Say no to governance that pushes people behind, that leaves people behind. As we speak, there is 4.6 billion people around the world, most of them in Global South, that don't have access to basic health services. The reform we are doing is not just about fragmentation, duplication, and resolving those issues. It is about giving health to the people. Half of the world's population don't have access to basic health care. If we just conform to fix the system, we know we are going to continue to leave people out of basic health care. So governance that is pro-equity. Governance that's pro-equity, there is an example, President Mahama spoke about the coverage of the national health insurance in Ghana. He knows exactly how many people in Ghana, what's the proportion of people in Ghana that are still not covered. That's the kind of governance pro-equity that we are looking for. The second shift is agency, not aid. Agency to influence, agency to negotiate and lead from the front with the kind of confidence and assertiveness that comes from the unique and bold purpose of the Accra Reset, and that is driving this process. Power and representation are important, and we need to lead from the front. Agency, not aid. The third point is partnerships, not paternalism. President Mahama mentioned that this morning. We are looking into 4 partnerships that are mutually beneficial, in mutually beneficial terms, not partnerships that are based on paternalism. We need partnerships that are based on local and global knowledge, not saviorism. And that's the only kind of partnerships that we want to accept, that you're going to accept for the Accra Reset going forward. Last but one, sovereignty, not charity. The time for disguised charity is over. A can-do attitude with the right mindset is emerging and should be nurtured, should be championed, and that's what Accra Reset should be doing. And then finally, accountability to the people. My brother RC mentioned that. So we have been doing accountability to the donors. We need to do accountability to the people. In the next 1 minute and 26 seconds that I have left, I'm going to mention 5 things that I think are important going forward. Political will. We don't mention enough. We say it all the time. Without political will, any good recommendation is going to fail. Moral courage is going to be important. Coherence across the board. Unity of purpose. If we are not united, we are going to fail. And then finally, last but not least, a very strong leadership from all of us, not just from the top, bottom, medium, all the levels need to demonstrate strong leadership. I thank you.
Thank you very much, Dr. Magda. Robalo, agency, not aid, political will, all of those things, very, very, very important indeed. That concludes our first panel. Put your hands together for Dr. Robalo, Minister C, Minister Duale, Minister Padilla in absentia, and Minister Budi. Thank you very much indeed. Thank you, panel. So shortly we'll move to our second and final panel on the future of financing transition. We'll have 1 or 2 bankers on the panel, people, money people. But first, a question, I suppose, how does this Accra Reset and the Africa Health Sovereignty fit into the overall WHO strategy? Well, the DG of the WHO is, of course, an African, Dr. Tedros Adhanom Ghebreyesus. We were hoping to have him with us. Sadly, at the moment, he's not able to be with us. But I'm delighted to invite Dr. Mohamed Janabi, the Director General of the WHO Africa region, to deliver remarks on behalf of Dr. Tedros. And if by magic, you are here. So, thank you very much. No. Okay, we have a little kind of tension going back to Lusaka last year.
Yes.
But I think it's eased now.
You cut me off.
I hope you keep in your mind's eye there's a clock right there, okay?
Exactly.
Even the president was on the clock. But Dr. Janabi, thank you.
Thank you, Your Excellency, President Mahama, Excellencies, ministers, colleagues, and friends. Thank you, Mr. President, for your leadership and for reminding us that this moment is not just for challenge, but of choice. Because we meet at a turning point. Our world is changing rapidly and profoundly, yet too many of our systems are not keeping pace. Our world is changing. Too often they remain fragmented, complex, and distant from the people they are meant to serve. And it is people, families, communities who, end of the day, pay the price. That is why the Accra Reset is so powerful. It is more than a reform agenda. It is a call for dignity, ownership, and trust. A call that says countries must lead. Countries must be heard. And countries must shape their own health futures. We know what is needed, but this time we must move from promises to progress, from commitment to impact. This means aligning financing with national priorities and advancing governance and financing together to build a system that works with countries, not around them. Excellencies, Africa this time is not waiting. Africa is leading, and the world is listening. Earlier this year, you took an important step by entrusting WHO to host a joint process to reshape the global health architecture, one that is country-led, inclusive, and coherent. WHO stands with you, not above you, not apart, but alongside you as you partner in this transformation. Let me close with this. Health sovereignty is not about standing alone. It is about standing together and standing together strong. The path is very clear. The momentum is real. Now is the time to deliver for our people in Africa, Africa Plus, meaning with our partners, with our diaspora, with philanthropists, with civil society, with religion-based society. That is what it means, Africa Plus. President Mahama, we are with you. In the past 6 months, I've been 3 times to Ghana from your invitation. We are working together. I thank you.
Very much indeed. All is forgiven, came in well on the time. So thank you very much indeed, sir. And it's great to see that the WHO, both at the global level and the Africa regional level, is firmly behind this Accra Reset, spearheaded by President Mahama. Now, our final dialogue today turns directly to the future of financing, transition, and institutional evolution. The central question here is not whether countries should lead, there is broad agreement on that. The real question is whether global financing institutions are prepared to evolve in ways that genuinely support sovereign, country-led systems over the long term. This discussion brings together leaders from multilateral financing institutions alongside a country perspective from Nigeria, one of the most consequential health system transition stories on the continent. Please welcome our panelists. From Nigeria, we are delighted to welcome Dr. Kelechi Ohiri, Director General of the National Health Insurance Authority, Mr. Peter Sands, Executive Director of the Global Fund to Fight AIDS, Tuberculosis and Malaria, Dr. Sania Nishtar, Chief Executive of Gavi, the Vaccine Alliance, and Dr. Priya Basu, Executive Head of the Pandemic Fund. Please welcome our distinguished panel. Dr. Kelechi, I remember the speech you gave, the very stirring, dynamic speech you gave at the Intercontinental last year during the World Health Assembly. You said, Nigeria is not waiting, we are moving. We are going to show you what we have done. Okay, well, let's see the evidence. Because we need to. Because what's interesting is Nigeria has been very deliberate, intentional about leveraging its relationships with multilateral partners, represented here, the Global Fund, Gavi, and others, to advance its own national health priorities. So please, we want evidence. Share with us a concrete example of where that approach has worked and what it required from Nigeria to make it work.
Like the way you say Nigeria.
No, it's because I have a lot of. No, there is love between the old days of Ghana was going on. That's ancient history. We don't want to recall the difficult times because we know who is now in Osu Accra. He's full of Nigerians. Anyway, I'm joking. No, it is. No. But joking aside, so we want evidence of where this new invigorated approach that you alluded to at the Intercontinental last year is working.
Well, thank you very much. First, Your Excellency, President John Dramani Mahama, good afternoon, and distinguished colleagues. Interestingly, about 70 years ago, a certain Ghanaian president actually made a push for sovereignty. But it was a different kind of sovereignty. It was a political kind of sovereignty. And then with that, Ghana became independent in 1957, a year later. And then other African countries followed swiftly, including Nigeria 3 years later. And it's quite auspicious that now another Ghanaian president is making a push for sovereignty, but this time in health and in development, and very certain that this momentum, will inspire fundamental changes across the continent on how future partnerships are shaped between countries and its partners. And So Nigeria remains proud, to be part of this movement, even though we have the better jollof rice, but I'll see how they feel.
When somebody
But-
brings in jollof, they're failing.
Well, you asked for specifics, so we'll go into specifics today.
Yeah.
So you asked for evidence, so I'll
Yes.
just focus on 3 areas, and I'll give 3. I think the first is on issues related to governance. The second is on how we have reformed financing. And the third is we operate a mixed health system, so we have done a lot of reforms in how we unlock the value chain, particularly in the private sector. The thing to note is that our journey preceded what we call the global shock.
Yeah.
In December 2023, His Excellency President Bola Ahmed Tinubu signed a compact with the states in Nigeria, given our federated structure, but also with partners, and created a strategy called the Health Sector Blueprint. And that became the foundation and the platform for coordinating activities across the entire country and our relationship with partners. And this set up something called a sector-wide approach. And I think it was mentioned, the whole principle of having one plan, one national dialogue, etc., was put in place. And that made it a bit easier to actually galvanize different partners and bring them together. Then at the last WHO, Nigeria, with about 20 other countries, sponsored a resolution on health financing and strengthening it. And some of the things that came up from that was emphasizing domestic resource mobilization, more transparency in financing, and thirdly, country leadership and stronger governance. This culminated in a health financing dialogue last year, where we brought all the stakeholders from the Ministry of Health to the Ministry of Finance. And as Minister Budi spoke about, you can't really go far in financing reforms without the Ministry of Finance. And so that sector-wide approach had led to one of the most remarkable coordinating mechanisms we've seen. The dialogue, we actually partnered with the Global Fund to convene a lot of those stakeholders. Then in financing service delivery, Nigeria basically went 2-pronged in that approach. So one, we committed typically 1% of consolidated revenue to primary health care. That has doubled recently when the Senate recently approved that money going to 2%, and that's in addition to the government's budget in health. With the Global Fund, we began to pilot thinking forward. How do we sustain financing for HIV, TB, malaria, etc.? And we began to pilot the integration of some of these vertical programs, not just in the health system broadly, but also in health insurance. And that has led to us actually successfully piloting that, revising our benefit package to actually include things like tuberculosis care, etc., in a way to move everything forward. And hopefully with the GC8, we're having conversations around how we can actually scale that up across the country. On unlocking partnerships for the value chain, we've done a lot. The president, sort of issued an executive order with 0 duties of VAT on machinery and raw materials for local production. We've mobilized resources from multilateral development banks. We have about 1.75 billion in facilities, of which so far we have actually mobilized about 175 million of that. We have 90 projects for which the term sheets have been included, and we have an active pipeline in partnership with EIB and in partnership with the Afrexim Bank. And we've also established Medipool, which is a group purchasing organization, also in partnership with development agencies. So a lot has been done. It's not possible to say such in a very short period of time, but across these value chains, we see a place where fundamentally the country, first of all, has to set out a strategy. You have to lead, you have to have charted direction, because you can't work effectively with partners if you don't know where you're going.
Yeah.
And once that is set, then of course, then you can then appraise the willing partners that you want to work with. And so far, we're fortunate we've had very good collaboration, some of the multilateral partners, to chart the direction that Nigeria is setting, built around that platform of a sector-wide approach of the Nigerian government.
Dr. Kelechi Ore, thank you very much indeed for the picture from Nigeria. And you talk about willing partners, and one of them is sitting to your left at the Global Fund, Peter Sands. And Peter, I'd like a couple of things. First of all, your brief reaction to the way Nigeria's gone about its business. And then Let me know, tell us how the Global Fund can serve as a key platform to support the Accra Reset agenda at scale, particularly for complex transitions.
Well, first of all, I think the Accra Reset is raising the bar, both on countries themselves and on us as global health institutions. And I think we have to acknowledge the President Mahama's leadership in making that happen. Nigeria is a really good example, actually. Nigeria is the largest recipient of Global Fund support. Over the next 3 years, we're providing a little over $800 million. Kelechi and I share one thing in common, which is we both have Mohamed Pate as our boss, because not only is he the Minister of Health, but he sits on the board of the Global Fund. He also chairs the country coordinating mechanism. So actually, he has a lot more control over what happens with that 800 million than I do. And that's good. Yeah. That's right. That's the way the Global Fund model is designed. It's designed so that countries actually take the lead in determining how the money is spent. They can shift money between diseases, they can shift money between the diseases and health systems, and they can choose what kinds of intervention to support. They can choose what implementing partners to use. But that is a starting point. But as I said, I think what Mr. President, you've thrown down is a kind of challenge for all of us to move faster and more ambitiously on the path towards country ownership, leadership, health sovereignty. And we are working with Nigeria on multiple aspects of it, either through the alignment with the sector-wide plan, or I think one of the things that we've done together that's really interesting has been these pilots of channeling the funding for HIV and TB through the national insurance scheme, because that's sort of making it an integral part of the way the whole system works. And we're also working on the sort of financial governance and accountability sort of mechanisms and capabilities. These, I mean, I confess I'm another one of these banker types. These bits of the underlying kind of financial infrastructure are absolutely crucial to ensuring that health sovereignty is built on very robust foundations, really sustainable foundations. Another aspect of what we're doing, and this is talking more generally than Nigeria, in supporting the move to greater health sovereignty, is working with partners on opening up. One of the sort of key assets the Global Fund has is pool procurement mechanism that enables countries to access quality assured commodities at scale. Now, at the moment, most of that is being bought using Global Fund funds, but increasingly that's going to be bought using domestic funding. And this isn't setting it up in competition with either national procurement agencies or with regional ones. The whole idea is that we want to support the development. And indeed, we've worked very closely with Kenya on supporting the strengthening and the development of KEMSA, for example. And today, actually, we signed an MOU with Jean Casser, who I know has had to go back, of Africa CDC. And one of the key elements of that is actually a collaborative procurement model, where a lot of things are best bought at a regional level, but there will be some product categories, either innovations or particularly small volume things, where you need global scale. So the whole idea is to work together. And that's one element of the MOU that we've signed together. I mean, fundamentally, I think the way sort of we look at ourselves in this is our role is to be an enabler. We're there to support, we're there to help make things possible, but the actors are the countries. They should lead, they should make things happen, and we should both be accountable for the parts we play in that. And that, I think, is a really exciting way of looking at the future. Yes, there are huge challenges. We've had massive disruptions in funding. There are lots of complexities about geopolitics. The epidemiology of some of the diseases like malaria is looking pretty challenging right now. But I think that model of how we work together is a great way forward.
Peter, thank you very much indeed for giving us a perspective of the Global Fund. And I'm wondering how that compares and contrasts with Gavi. We have Dr. Sania Nishtar here. Thank you for being with us. And of course, Nigeria is one of Gavi's most significant and complex partnerships country-wise, and it reflects many of the wider shifts happening across global health. So I'm just wondering, given what Peter just said, how Gavi is evolving its partnership model in practice, both in Nigeria specifically and more broadly, because people say country-led, but of course, you still want to make sure, if you're dispersing, that things are used for the purpose for which they were intended.
Well, first of all, let me thank President Mahama. You continue to inspire us with your attention to global health. We are so grateful to you. And I want to thank you all for honoring us with your presence at the Global Health Campus this evening. Nigeria is indeed a very important country for us for a number of different reasons that Peter outlined. And what Nigeria is doing in terms of its governance of engagement with international entities is one expression of country sovereignty, because they talk about one budget, one plan, one set of indicators, one set of monitoring, and that's cardinal to the health sovereignty movement. The other expression of health sovereignty is sitting right in front of us, because not many of you may know that Ghana is contributing significantly to its domestic vaccine budgets. Last year, they contributed $25 million in hard cash into a bank account to underwrite the cost of their vaccines. And this year, ahead of schedule, they've paid $22 million in hard cash. That's another expression of a national sovereignty. We talk about dwindling official development assistance, but I think there is a huge upside to that, because all over Africa in particular, countries are rising and saying, we are going to underwrite the cost of health, because we fundamentally believe that the definition of sovereignty is to be able to mobilize indigenous revenue and to be able to deliver services to their populations. Now, in terms of your question, how is our model changing? We are basically aligning with the sovereignty movement. This is what the Gavi Leap is about. This is how we've pivoted, because we made a decision 2 years ago, as we read the tea leaves, as we saw the cards playing out, that we're not going to wait for the World Health Assembly to give us normative guidance on how to restructure, that we have to reform ourselves today. And we're quite further along in that journey in transforming ourselves. We are basically, the Gavi Leap is basically Accra Reset in implementation. The Gavi Leap is the Lusaka agenda in implementation. And we've actually taken tangible steps to recast our model. I'll give you some examples of that. For instance, we are ceding decision-making to countries. They are now taking decisions on how to allocate prioritize their vaccines and vaccine budgets. They're deciding who to choose as technical partners. We've radically simplified our model after 2 years of hard work, because this is what we heard from countries. They said, we greatly value Gavi, but your processes are very onerous. We've worked incredibly hard to radically simplify and to end-to-end digitize our processes and to give real-time visibility to countries. We are also investing over $100 million in strengthening fiduciary systems and of taking solutions to the system solutions to scale. Today, every health minister is grappling with some of the constraints that are endemic to public primary healthcare systems. Hemorrhaging supply chains, rent seeking in procurements, pervasive absenteeism, and many health ministers are deploying some very radical solutions to overcome those constraints. We just heard from the Honorable Minister of Health of Kenya about the distribution chain security solution that he's deploying. At Gavi, for instance, one of the things we've decided is we're not going to pay per diems on the ground, exceptions notwithstanding, unless payments are made through cell phone payments. Simple solution, but needs to be deployed at scale. And then, of course, we are, and I say this with a lot of humility, we are investing in Africa's future with respect to vaccine manufacturing and the dream of vaccine sovereignty, and they have every right to have that dream, and it is our responsibility to support them. You know, the African Vaccine Manufacturing Accelerator is an example of that. We deployed that solution as a subsidy instrument. We kept our ear to the ground, and we heard that Africa wanted modifications. So this July, I'm taking a package of interventions to modify that subsidy instrument to be able to invest in the pre-financing they need, to be able to invest in the ecosystem support that they demand, to be able to bring to the table demand guarantees, which are going to be a very important component of African vaccine sovereignty. And so we are very humbled to be investing in the future. So I just want to reiterate that the Gavi LEAP reform and the restructuring that we've done is based on what we've heard. And it's a response to what Africa wants. And of course, we are very happy to share lessons as we learn from the deployment of the reform. And we look forward to working closely with the Accra Reset initiative. And we look forward to pivoting even more based on what the continent wants.
Tremendous, Dr. Sania. Nishtar from Gavi, thank you very much. It's great to see that you're aligning with the agenda, the Lusaka agenda, and that you're pivoting and doing a lot of hard work and introspecting as well to change the way you do business. Let's talk to Dr. Priya Basu from the Pandemic Fund, which was established at a time when there was increasing demand for more country-led approaches to global health financing. Just thinking about the backdrop, Nigeria was identified as one of 15 eligible countries in the Pandemic Fund's fourth calls for proposals. So I'm wondering what this partnership represents for the Pandemic Fund and how you're working with this gentleman to my left, in his country, and other African countries to co-develop programs and financing approaches aligned with national priorities and long-term health goals.
Thank you very much, and Your Excellency, President Mahama. Thank you for your leadership, honorable ministers, ladies and gentlemen. It's really an honor to be here, and I'm very proud to be serving on the Accra Reset high-level consultative group. It's really a privilege to be part of a process of reshaping a health architecture that prioritizes sovereign capacity. So we are a new fund, relatively new. We were set up towards the end of 2022 based on the lessons from COVID-19. And we've moved forward very quickly. Just to give you an idea, we already have a footprint in 128 countries, a portfolio of 11.5 billion, supported through 67 projects. We benefited from the fact that we were set up based on hard-earned lessons from other global health funds, and so you could say that our model is designed ahead of its time. We are structured in a way that we do not believe that ODA is limitless. So every dollar of grant funding that the Pandemic Fund allocates crowds in resources from multilateral development banks, from global health initiatives, and very importantly, from the countries themselves. For every dollar of grants that we've awarded, we have been able to mobilize crowd in $7, $4 of which is from international partners, but very importantly, $3 from the countries that have received our funding. And I just want to say, before I speak about Nigeria and our partnership, which we're of course very proud of, that Africa as a region has actually brought in 3 times as much in its own money, its own co-investment, as what the Pandemic Fund has provided. So really sovereignty. Through our 3 rounds of funding, we allocated a little over 600 million to 27 African countries that have put in $1.8 billion of their own resources. So I just want to kind of highlight that. And we are, of course, country-led, very much country-driven. Our resources go on budget, importantly. So again, just to ensure that really countries are making their own decisions in terms of how they want to use our financing, and they're putting their own budgets, their own skin in the game. So Nigeria, of course, we're very proud to partner with Nigeria under our 4th round of funding. That 4th round actually makes available $250 million to 15 countries that have been identified as those that have the highest risks, greatest capacity gaps, biggest needs. And Mohamed Pate, of course, is well known to all of us. He was actually at one time my direct boss a few years ago. And we are excited to work on a One Health approach, really integrating the nexus between animal health, human health, and the environment, given that so many zoonotic diseases that have pandemic potential really start in animals, and we're just living through one right now. And maybe just zooming out a little bit on the African continent, I wanted to share that we are, as I mentioned, supporting 27 countries in Africa. But we're not just working at the country level, but we're also working at the regional and sub-regional level, because we do believe that pandemics don't respect borders, they don't need visas. So we have really interesting regional projects in the Greater Virunga landscape, for example, in the IGAD region, with AU IBAR, which is an organization that deals with animal health and helps connect human and animal health, and of course with the Africa CDC. So we're looking forward to all these, to realizing all these partnerships and to taking forward the work that we're just starting in Nigeria. Thank you.
Tremendous. Thank you very much to Dr. Priya Basu. It's a new fund, but it sounds like you've hit the ground running and you're taking advantage of some established partnerships and developing some new ones as well. So thank you very much. That's it from our panelists. Put your hands together for Dr. Priya Basu, Dr. Sania Nishtar, Peter Sands, and Dr. Kelechi Ohiri from Nigeria. Thank you very much indeed. Now, what we've heard throughout this discussion is that transition cannot simply mean withdrawal. It must mean partnership evolving toward greater national agency, stronger systems, smarter financing, and shared accountability. And perhaps most importantly, that sovereignty and multilateralism are not opposing ideas. They must succeed or fail. I've got one more person to invite here, Dr. Naveen Rao. Is Dr. Naveen Rao here? Sir? Our Supremo, Rockefeller. Thank you very much, Dr. Naveen Rao.
Your Excellency and friends and distinguished guests. Wow. It's my honor to provide closing comments, and I also realize I'm between you and the refreshments, so I'll be brief. It is an honor for me to provide these closing comments. Like many of you, I have been coming to the World Health Assembly over years. I don't even know which one this is. But quite often I've left here feeling that I have a sense for what the world or what we need to do. But this time I feel when I leave, I'm going to leave with a sense of actually something will happen. So I feel that is a difference. People have asked me, is Accra Reset all talk? Is it all just podium presentation, or is there any action happening? I must tell you that 7 African countries have come together under a rubric called the Communities of Practice, and have actually built and are already building transition plans and development plans that they will surface to the high-level panel and will get to the presidents and the high-level. So work is happening. It is not all talk. And on behalf of the Rockefeller Foundation, I want to say clearly that we believe that what is being built here is real, and we are committed to supporting it. What stood out for me today was the fact that countries are deciding that sovereignty is in the center and not in the periphery. And that is something we should all celebrate and support. There are a couple of points that came to my mind. The first is probably the hardest to say, and I'll say it upfront, is this is too big to fail because of politics as usual. So we need to work together and not just talk about it. How we'll get from here to there is going to be difficult. There will be times will be tested, but how we come out of this is really important because there is a real person there waiting for us to get our act together. And I really do believe we're very close this time around. The last point I want to make is we do need unusual partners. Nice to see the bankers, nice to see the money here, but where is the private sector? Where are the other partners that can come in? What are the novel ways we can get better health, whether it be through insurance or domestic financing? So we do need to work together with unusual partners. And again, we will do our best here. If we do that, we will not just be repairing old systems, but we'll be helping to build one that is truly fit for the 21st century. And this is something the president has mentioned directly. All of this depends in the end on people and the choices we make. I look around at the assembly every year and I still see a world full of people who have chosen to spend their careers and their lives trying to do the right thing. That commitment outlasts any single political moment. And it is, for me, enough to keep going. Thank you.
Thank you very much indeed, Dr. Rao, on behalf of the Rockefeller Foundation. Thank you very much, Dr. Naveen Rao, Senior Vice President for Health at the Rockefeller Foundation. Thank you for those reflections. And with that, we bring the formal proceedings of the Geneva Clarion Call to a close. On behalf of the Accra Reset and the Republic of Ghana, thank you very much, Mr. President, for you being here. Thank you to our speakers and ministers, delegates, partners, and live stream audience around the world for joining us today. The conversations in this room have made one thing very clear. The future of global health will not be defined only by institutions or funding flows. It's going to be defined by whether countries have the power, capacity, agency, and partnerships required to lead their own development journeys. Thank you very much for your engagement and participation. I'll ask you to stay in your seats for a moment because we'd like to invite all the speakers to go over to the, I think it's called the media wall over there, stage left, to take a photograph. Mr. President and Mr. Health Minister, Vanessa, all our speakers, Peter Sands, Sania Nishtar, Priya, Basu, His Excellency Budi and Pate have gone, but Aden Duale, Mr. C, Magda Robalo, DG, WHO, Africa region, Prof, I think you are still here. Could we have the picture, the photo de famille by the media wall? Huh? Everybody else, please. We're going to have a wonderful drink outside. The forum is going to be a networking reception with drinks. Who knows, there may even be some banquet tilapia, I'm not sure. But have a wonderful evening, and thank you very much indeed for being part of the Accra Reset. So stage right, everybody else, please, if you kindly leave the auditorium and enjoy the networking reception out there. Thank you very much indeed. You've been wonderful. Thank you very much indeed. Thank you. Thank you. Please, only the speakers over by the media wall. Thank you very much indeed. Thank you. Thank you.